Yeah, hi doctor, this is Rubia from the technical team. Am I audible?
Good evening.
Yeah. Sir, we are live now. Yes, sir. Yes.
Doctor.
Yes.
Good evening, everyone. I'm Dr. Gaurav Tamboli from Nandurbar. So today we are discussing a very nice topic, understanding glycemic variability in high carb diet. There is a role of remogliflozin in the Indian type 2 diabetes mellitus patients. So the today's agenda of the lecture will cover like diabetes burden, global and Indian carbohydrate burden, carbohydrates and glycemic variability, clinical impacts of this glycemic variability, continuous glucose monitoring and time in range. There is a new matrix in the control, guideline recommendation, role of SGLT2 inhibitors in glycemic variability, remogliflozin evidence on GB and postprandial control, remogliflozin in special populations. So, coming to the global epidemic and Indian perspective, the type 2
Sir,
diabetes.
sir, hello, hello. Sir, sorry to interrupt, but request you to please share the slides.
There is no slide here.
Sir, I'm sharing.
You have to open the slide here.
We need to share the slide.
बात कर लो तो स्लाइड कैसे इधर डालो.
Kamran, can
No,
you
sir,
share
no,
from
no, no, no.
laptop?
Yes, sir.
Can you share from laptop? Screen sharing and same process.
नहीं.
I'm trying.
So there is an issue in sharing the slide. So can you just guide him? यहाँ पे ना आप लोग ये ओपन करना पड़ेगा इसमें.
Kamran, just open that file. Kamran, if you are
Sir, just a minute.
okay, fine, I can.
Hello, sir. Sir, you have connected through multiple devices. Please put the volume on zero of another device.
Sir,
Yeah, the slides are yet not visible, sir.
is it visible now? Is the slide visible now?
Yes, sir. Yes, sir. We can start, sir. Please continue, sir. Thank you.
Okay. Am I visible to you?
Yes, 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 sir. Visible clearly. We can start.
So I will start again. Today we are going to discuss about the glycemic variability in high carb diet patients, and there is a role of remogliflozin in Indian type 2 diabetes mellitus patients. So the agenda of today's lecture is to understand the diabetes burden, global and Indian carbohydrate burden, carbohydrates and glycemic variability, also clinical impact of this glycemic variability, continuous glucose monitoring and time in range, the new metrics of control of glucose, then guidelines recommended. There is a role which will going to discuss for SGLT2 inhibitors in glycemic variability, remogliflozin's evidence and postprandial control, remogliflozin in special populations. Slide share. Sharing.
Okay, sir, change the slide.
हाँ ये चला गया ना. So, according to the International Diabetes Federation, the latest update in 2025, which is suggestive of there is 589 million adults, means 6 crore of adults are living with diabetes in worldwide.
that reflects 1 in 9 adults globally is affected by diabetes. The number is projected to rise to 853 millions by 2050. 81% of the adults with diabetes live in low and middle income countries. The earlier dictum was it is a disease of the rich. It has now changed dramatically. Diabetes caused 3.4 million deaths in 2024 alone. 252 million adults remain undiagnosed globally. So the ICMR study, which published recently, suggests of there are 100 million, that is 10 CR peoples are now diabetic in India, which is up for 44% in last 4 years. So carbohydrate is the cause of rapid rise in diabetes in India. So we will just learn that Indian population consumes high amount of carbohydrates among the global populations. So what does carb do? Or there are major risk factor which is the cause of diabetes in India. There are four: increase in the calories, that direct glycemic load, physical inactivity, urbanization and pollution, also sedentary lifestyle, depression and stress. So the change in dietary habits over decades increase the consumption of processed food, imbalance between energy intake and expenditure on day-to-day basis. Impact of carbohydrate intake on glycemic control. Indian diet derives 62.3% of total energy from carbohydrates, predominantly from the refined cereals and added sugars. Higher carbohydrate intake was associated with 14% risk of type 2 diabetes and 15% risk for pre-diabetes. Refined carbohydrates, added sugar showed stronger association with adverse glycemic outcome. Replacing carbohydrate with protein, that is plant, veg or non-veg sources, was associated with lower the glycemic risk. International interventional evidence supporting carbohydrate restriction. Supporting evidences from the Indian prospective study demonstrated that adoption of the low carbohydrate diet in adults with type 2 diabetes was associated with favorable glycemic and metabolic improvement. The dietary intervention was linked to improved glucose regulation along with beneficial changes in the overall metabolic profile. These findings complement national observational data by suggesting that reducing carbohydrate intake may have therapeutic value in type 2 diabetes management. Together, these studies emphasize that both carbohydrate quantity and quality are important determinants of glycemic health. So, what is glycemic variability? Glycemic assessment in diabetes a necessity for parameters beyond HbA1c. So earlier there was a triad. Now we the changing dynamics suggest of pentad. HbA1c cannot assess the hypoglycemia or glycemic variability. It just shows the uh, past 3 months overall glucose control, but it does not provide information for frequency, duration, or magnitude of the short-term fluctuations in glycemia. It does not reflect intra or inter-day glycemic excursions. Gets easily affected by conditions like renal disease, hemoglobinopathies, chronic liver disease, and iron deficiency anemia. So, HbA1c alone may not exactly reflect glycemic control or exposure. दिख रहा है? So there is a shift in diabetes management from glycemic triad to glycemic pentad. So earlier it was HbA1c, fasting glucose, postprandial glucose. So now there are two inclusions, that is hypoglycemia and glycemic variability for the better outcomes. So glycemic variability, hyperglycemic memory, glycemic excursions trigger oxidative stress, increase intracellular ROS cause defective angiogenesis, active pro-inflammatory pathways, long-lasting epigenetic changes, and this continues even in the normoglycemia state. That it triggers in the hyperglycemic state and this continues in the normoglycemia state. Hyperglycemic memory. Glycemic variability is a consistent predictor of hypoglycemia. Hypoglycemia is associated with significant morbidity and increase in the mortality. Frequent or large glucose fluctuations independently contribute to diabetes related complications. Increased glucose variability associated with mortality in ICU. Glycemic variability is better predictor of hypoglycemia than HbA1c. So, glycemic variability and diabetes complication. Importance of maintaining the TIR. Increased risk of severe hypoglycemia. So the role reflects in five main components. That is the risk of hypoglycemia, microvascular complications, cardiovascular autonomic dysfunction, microvascular complications, and increased cardiovascular events. So CGM and time in range theory. There is a chart. I'm not going in deeper. The standardization of CGM metrics for clinical care. So, how does CGM work and how we assess it? It is given this standard chart. So the Journal of Nutrition has suggested the relationship between dietary patterns and glycemic variability in people with impaired glucose tolerance. So the fact is, diurnal glucose fluctuations are increased in the prediabetes and might be affected by specific dietary patterns. The aim of the study was the relationship between glycemic variability and dietary regimen in people with normal glucose tolerance and impaired glucose tolerance test. The result were positive correlation was observed between glycemic variability and high carbohydrate diet, negative correlation between glycemic variability and protein intake. So, GV version with the increase in overall daily carbohydrate and refined grain consumption, and improved with the increase in the whole grain intake and protein intake, IGT. So, pharmacotherapy of the diabetes according to ADA. So, the goal is cardiovascular and kidney risk reduction. Main goal to control the long-term side effects of hyperglycemia. In that, ASCVD increase indicators of high CVD risk, heart failure, CKD. So, this chart ultimately going with the additional cardiovascular and kidney risk reduction, management of other metabolic comorbidities or glycemic lowering is if needed, plus mitigation risk of MSLD or MASH. So agents with proven or potential benefits in MSLD and MASH are GLP-1RA, dual GIP, GLP-1RA, pioglitazone, combination of GLP-1 with pioglitazone, use insulin in the setting of decompensated cirrhosis. So there is other goal, achievement of maintenance of the weight and glycemic goals. So glycemic goal along with the control of body weight is also important. So efficacy for glucose lowering very high. Dulaglutide, high dose, semaglutide, tirzepatide, insulin, combination oral combination with injectable GLP-1 RA and insulin, high at the GLP-1 RA, metformin, pioglitazone, SGLT2 inhibitors, sulfonylureas, and intermediate is DPP4. So effect of twice a day dosing over once a day in glycemic variability control. So there is a study published in Journal of Diabetes Treatment, a prospective multi-center open label study to assess effect of remogliflozin on glycemic variability compared to dapagliflozin using continuous glucose monitoring. The study was named the REMIT GV study. So the study was randomized. Treatment duration was 6 weeks. Sample size was 75 people enrolled. Final analysis was done of 65 patients, 33 in which of remogliflozin, 32 were on dapagliflozin. So the primary objective was to evaluate the effect of remogliflozin on 24-hour glucose profile assessed by parameters derived from continuous CGM in Indian patients of type 2 diabetes. Secondary objective was to evaluate safety and tolerability of remo in comparison to dapagliflozin. So the study flow was like this. There was 7 day, the first CGM and second CGM. The first 7 days pre-treatment, the CGM was used. Then this other later 7 days post-treatment phase one, and there was a day 36 to 49 for post-treatment phase two. So we used CGM for total 28 days in this study. The baseline data was captured in pre-treatment phase for first 7 days, and the long-term and mid-term effect were captured in the phase one and phase two post-treatment CGM studies. So the mean change in the continuous glycemic profile across 24 hours from baseline to phase 2, high carbohydrate meal and PPH in Indian type 2 diabetes patient. So there was a peak post breakfast, post lunch, and post dinner. So more reduction is seen with the remogliflozin compared to dapagliflozin, especially at night. It was observed during this study. So Final conclusion from this study was postprandial hyperglycemia is an independent risk for CVD and has shown to further increase the risk of CV events in diabetic patient. Indian meal pattern of high carbohydrate meals per day contribute to more postprandial hyperglycemia. Results were significant improvement in TIR and HbA1c levels within both the groups, but no difference between the groups. Significant improvement in postprandial glycemic parameters, that is MPPGE, PP1 hour and PP2 hours with the remogliflozin, but not significant with dapagliflozin. Significant improvement in postprandial glycemic parameter at almost every meal time, out 8 out of 9 with remogliflozin, but fewer, that is 3 out of 9 with dapagliflozin. Similar adverse event found in both the groups. So remogliflozin might be better in the direction reducing glycemic variability with effect to postprandial glycemic control in type 2 diabetes mellitus patients in Indian population. So use of SGLT2 inhibitor plus DPP4 inhibitor combination for glycemic control. So there is one more study which with the objective of assessing efficacy and safety of FDC RMV in patients who were previously uncontrolled on dual drug therapy of metformin plus SGLT2 inhibitor or metformin and DPP4. So we are just this study its inclusion criteria was Indian adult should be more than 18 years of age and less than 65 years of age with either gender and diagnosed with type 2 diabetes for more than 6 months, ongoing dual drug regimen on stable dose of metformin with DPP or metformin with SGLT2 since last 12 weeks before screening. Daily metformin dose on 1000 or 2000 mg per day. Uncontrolled glycemia with HbA1c more than 8 at the time of screening. Patient willing to provide signed and dated written informed consent prior to any specific study. So there is a result, efficacy result comparing the glycemic parameter between baseline to 12 weeks and 24 weeks. So initiation of FDC with hemoglobin showed significant reduction in HbA1c, fasting blood glucose, postprandial blood glucose, and baseline for both 12 and 24 weeks. So, after comparing the blood pressure, weight, waist circumference between baseline to 12 and 24 weeks, significant blood pressure and weight reduction over 24 weeks has been observed with treatment of fixed dose combination of RMV. Overall, 4.7% of patients experience adverse events of special interest like hypoglycemia, that is 1.9%, UTI 1.9%, and genital tract infections 1%. No SAE was observed during the study. Triple FDC was well tolerated, safe, and effective in type 2 diabetes patient and control on dual drug therapy. So there is a summary of other adverse events given, not significant at the moment. So there is one article publishing current trends in internal medicine on which efficacy and safety of combination of remogliflozin, etabonate, and vildagliptin as fixed dose in patients with type 2 diabetes mellitus. A randomized active control double-blind study, which is called Forever study. So the results were significant change from baseline HbA1c levels in both the groups. At the end of the duration, that is 16 weeks, there was a statistically significant change from baseline in the HbA1c levels in both the groups. That is 1.46 in the RV and 138 in the EL group. So other observations from this study was statistically significant change from baseline to 16-week fasting glucose and postprandial glucose level were seen in RV group and EL group with no statistically significant differences seen between the groups. Safe profile for the both FDC were compared. FDC of remogliflozin and vildagliptin was found to be non-inferior to FDC of empagliflozin and linagliptin in terms of efficacy and safety. So it is comparatively equally safe, remogliflozin and vildagliptin. Safety of remogliflozin in comorbid conditions. That is an important topic here. The novel evidence of remogliflozin in chronic kidney disease patients. A prospective multi-center randomized non-inferior study to evaluate the effect of remo 100 mg versus DAPA 10 mg in addition to the standard of care in patients of type 2 DM with chronic kidney disease. So the objective of this study was to evaluate the effect of remogliflozin on the renal parameters in patients with type 2 diabetes mellitus with CKD and non-inferiority with dapagliflozin. The duration was 6 months. There were 150 participants with the EGFR more than 25 were included, and within the range of 25 to 60 of the EGFR. So the group allocation was like remogliflozin group are 75 patients and DAPA group for 75 patients. So the Remo CKD results, change in HbA1c fasting and postprandial at the 12 weeks and 24 weeks were compared at the baseline. The summary I have shown here. So the result, that is non-inferiority parameters, more than 50% sustained decline in estimated EGFR at 24 weeks. It was observed in remogliflozin, the 99.46% patients and 6.67% in dapagliflozin group. Reaching end stage renal disease were observed in 4% and 2.67% compared to each other. No cases of cardiovascular renal death were added to current background therapy in the patients with EGFR. So the overall adverse effects in remogliflozin group was 26% versus dapagliflozin 24%. That's all for today. Thank you.
Thank you, sir. Thank you very much. So we can conclude.
Hello.
Hello.
Yeah, can